Dear colleagues, ladies and gentlemen, good morning. I'm just wondering whether you could answer a very simple question. When was the first breast cancer published? I'm so happy that I could get hold of a about 5-meter long papyrus. Unfortunately, I cannot read it, but somewhere here is the first breast cancer described. And that was about 5,000 years ago. Between this time point and 1970, what happened when concerning diagnosis and treatment of breast cancer? Unfortunately, you can answer it with one word: really nothing. Not only for centuries, but for thousands of years, it has been women who brought this kind of disease to the attention of their physicians. Poor physicians in the generations before us, what could they do with this? All of the breast cancers were very advanced, and that means that at the time of diagnosis they were systemic. But that doesn't mean that at the beginning they were systemic. Certainly Hippocrates was a very smart physician, but look at the single word he describes breast cancer. It's incurable. And you love art, so I take you to the time of Raphael. He painted his girlfriend with a breast cancer. She was dead 2 years later. Now we go to a very advanced country at that time, mid-1800, the United Kingdom, and look at the surgeon's leading book. Describes breast cancer once again with a single word. It's a hopeless disease, and it stayed so all the way to our generation. I think myself and you should be very proud that we are the very first in the history of medicine who can provide a significantly better outcome for the breast cancer patients. And let me put my foot down, it's not because of chemotherapy. It's because of early detection and most of the time surgery and sometimes additional treatment methods. So the goal is to get rid of our arch enemy. Let's steal time from breast cancer, go back to the point where she already has it, but she doesn't know about it. There was a revolutionary invention in the mid-70s, the discovery of low-dose film screen mammography. And then we found hundreds and thousands of baby cancers, in situ carcinomas, 1 to 14 millimeter invasive cancers. So we tried to arrest this process any time before it arrived here. Because, as you very well know, advanced cancer is very close to breast cancer death, not in all the cases, but most of the breast cancer death is caused by advanced cancers. Thousands of patients, survival curves, advanced cancers, and smaller cancers. Ingenious epidemiologists in Cambridge University declared that you cannot control the disease unless you reduce the advanced cancer rate and absolute number in a community. So actually I got the task to tell you how early detection explains saving lives. I'm not talking about mammography, because there are radiologists producing less good mammography and other radiologists who produce brilliant mammography. I'm talking about early detection. And the randomized controlled trials provided the opportunity to study the mechanism. How come that early detection works? Well, everybody can understand that the first generation prognostic factors, tumor size, axillary node status when the pathologist examines the nodes, and the histologic malignancy grade are the most important prognostic factors. And dear colleagues, this is immediately a take-home message. If your breast center, let's say, diagnoses 100 breast cancers a year, 200, 500, and these are all cancers exposed to screening, that is, screen detected plus the interval cancers. And then you ask me whether you are doing a good job or not. I would look at your books and I would say, don't show me your carcinoma in situ cases. Show me your invasive cancers, and there has to be more than 50% of them baby cancers, which we call 1 to 14 millimeter. Now that's the prerequisite to cut back on advanced cancer rate and decrease mortality. If somebody is falling in love with calcifications, there will be 50% of all cases in situ carcinoma, and you think you are doing a good job, you're not. The second is that about 15% of all invasive cancers are born aggressive, that is poorly differentiated. So therefore, the second criterion is at least 30% of the poorly differentiated cancers should be baby cancers. And then 70 to 75% of the cancers exposed to screening should be node negative. TNM classification, tumor size, and the node status. Now, if we cut back on both of these, then the stage 2, 3, 4 cancers are going to decrease, and so then we produce something nobody in previous generations had ever been able to do. And because there is a parallelism between advanced cancer rate and mortality, you are going to see how this is going to decrease mortality. So we are talking about a paradigm shift. We cannot tell the patient that I am going to cure you whatever stage your cancer is in. No, we have to go back in time and arrest this little process, so we are going to get rid of these. And we can express it very nicely with images. But to be enthusiastic about finding small cancers is one thing. To translate this into answering the question, are you really decreasing mortality or not? It required a very cruel trial. It's called randomized controlled trials. The idea came up in the early 60s in New York, when Sam Shapiro and Philip Strax went to an insurance company. That's why it's called HIP study, Health Insurance Plan. And they were asking for patient charts of 64,000 women. And of course, they didn't ask permission from the women. They just split it into control group, study group. And then they started to perform screening, namely, they did physical examination and mammography. I don't dare to show you the quality of the mammogram at that time. But they were lucky because the cancers were humongous at that time. Stage 3, stage 4. So even if palpation provided most of the benefit of so-called early detection, it paid off. 30% significant decrease in breast cancer death. Is this earlier than this one? Yes. Is it early enough for us today? No. So the results indicated that diagnosis and treatment of breast cancer in an earlier phase could prevent deaths from breast cancer, confirming that the Fisherian idea that it's systemic disease from the inception is totally wrong. But then in the 70s came the low-dose film screen mammography, and so we went further down from stage 2 to these 1 to 14 millimeter invasive cancers, carcinoma in situ, and then science immediately asked the question, is there any more benefit to collect in terms of mortality? Now, we really had to carry out that truly cruel trial, which is called the Swedish two-county trial. And of course, I have to give credit to all the other, altogether 8 population-based trials that have been carried out during the 80s. Two-county trial, it's also called WE. Let me just entertain you with one thing. The country is very long, and it has 24 counties. You would call it provinces. The Americans would call it states. Anyway, there are 24 of them, and in the Swedish alphabet there are 29 letters. So one of them got the A and the second B and C, and the county where this study was carried out happened to be the W and the E. It's not West and East. Dear colleagues, we deliberately did not use physical examination. We wanted to test the low-dose film screen mammography, and yesterday somebody asked the breakdown of the number of women in the group invited, control group 40 to 49. It's about 35,000 women out of the 133,000. And now this is a new era, so we had to go to the local parliament and discuss this with women and had their consent. So they allowed to carry this out, and this has been published so many times. I just want to show you 1986, I formed a research group, and since that time we meet and workshops twice a year. We published it, and actually we delivered what people expected, namely we decreased the stage 2, 3, 4 invasive cancers significantly, and that resulted in 31% decrease in mortality. Did I say we tested mammography? We did not. We tested early detection. Now, at that time, the tool was mammography. Tomorrow, fortunately, there will be mammography and ultrasound. And I really dislike to hear that MR moves the time of diagnosis forward, but there is no randomized control trial. You don't need to. Any tool that succeeds to steal time from cancer and therefore cuts back on the advanced cancer rate is going to decrease mortality. That's the benefit of our trial. That is indeed when the advanced cancer rate dropped at year 4. At year 4, mortality started to go down. And it stays there. It stayed there for 30 years. So the present findings and the findings from New York and from Netherlands, and now we can say 8 other trials as well, really clearly showed that early detection is effective in reducing breast cancer mortality. It was very important to put out this 29-year follow-up article. Dear colleagues, this is where the trial had to be stopped because of the highly significant decrease in mortality. And here is the 29-year mortality result, not survival. Be very careful. That's a different thing. We are not talking about the impact of screening. No, it's invitation to screening, which means the non-attenders are included here, and 30% of those who are on this line actually comes from the non-attenders. Had we chosen the control group to be the study group, the invited, then there would have been 15% non-attendees as it was here. Let's be fair, invited and non-invited. And it was great feeling that the first Alex Margulis award we get for this. It was great feeling at the RSNA, even if I was not there personally.